meeting. So, welcome to the CQC April board meeting, which yet again we're having remotely via Microsoft Teams. I don't think we have any apologies, we're all here. I particularly want to welcome Paul Kirby, who is our Equalities representative today. Paul's the Vice Chair of our Disability Equality Network. Paul, you're extremely welcome, and please feel free to contribute if and when you wish to. Is there anything that anybody needs to declare that's not already declared? Okay, that's good. And then we've got the minutes of the meeting of the 18th of March. Are they a true and accurate record of everything we discussed? Perfect. Unusually, there's nothing actually on the action log. That does not mean there hasn't been a lot of action. In fact, there's probably been an unprecedented amount of action, but nothing coming out of specifically out of the last sort of board minutes. Is there anything arising that's not otherwise on the agenda anybody needs to raise? In which case, let's move swiftly on to the executive team report. And Ian, can I hand over to you, please?
Thanks, Peter. I think that we have a substantive item in a moment on our response to COVID-19, and colleagues will want to talk about the detail of the work they've been doing in their respective areas. But if I just talk at a headline level, as I guess by way of introduction, firstly, I just want to record my thanks publicly to all of our colleagues for the flexible way in which people have responded to working from home. I think this has been undoubtedly a real challenge, both in terms of those people who have, if you like, more conventional living arrangements, but a number of our colleagues have not. They live in relatively small places. They don't have outside spaces and so forth. And we've asked them to do their regular work. We've asked them to talk about sensitive and emotionally difficult issues, and they really have risen to the challenge. And we've even been able to move our customer service centre to work remotely as well. So one of the, I guess, relatively few organisations that have been able to do that at the sort of scale that we've done. So I'm particularly grateful for the work that the colleagues have done and the way they've gone about that, the spirit in which they've shown. We have well over 100 colleagues now who are either seconded out or volunteering elsewhere across the health and social care system. We've got colleagues working certifying deaths in death certification teams. We've got colleagues who've been called up in the reserve forces who have been moving PPE about. We've got colleagues who are special constables who are now working on a semi-permanent basis as a police constable, as well as roles supporting NHS England and Public Health England, where we've got people seconded to support colleagues there as well. That's alongside a number of doctors and nurses who've returned to frontline practice. We've got people in A&Es and ICUs and so on. So I think when we talk about supporting the overall national effort, I think we do need to recognise that it's a range of different things that colleagues are doing. And we've tried to enable that to happen, whilst at the same time being true to our purpose, which, of course, we've said many times before, is to give public assurance that the health and social care system is safe to use and to promote improvement and knowledge sharing within that cohort. So in terms of activity, I think we've done a lot of things, and we'll talk in detail about that at the moment, but sort of headlines are supporting the setup of the various Nightingale hospitals. There's some really impressive people operating those Nightingale hospitals, and when colleagues have visited, they've remarked on how fantastic spirit, and also the willingness to learn and improve, which again has been a particular feature of the Nightingales. We were also approached on Monday, Thursday to help book people into drive-through testing centres. So they would be people predominantly in social care who were beginning to display symptoms of COVID-19 and needed to have a test to ascertain whether they did in fact have COVID-19. And those tests were being offered at a range of drive-through locations across the country. There's been a great effort by a number of colleagues who have managed to book in over 22,000 people now into appointments to have COVID-19 tests done. And we're also working closely with Public Health England and the Department of Health and Social Care on the distribution of postal testing kits to be used in care homes and potentially elsewhere. I think the important point really is that our technology and our people, and I think this is important to stress. This is about technology, but also colleagues, particularly in the NCSC, have worked incredibly hard to create an end-to-end service here, which has been really effective, and to be able to do that from a standing start. And we're now offering that service to a range of key workers as well. In terms of upcoming areas of interest, there's a reporting process that we are now coordinating with our colleagues at Department of Health and Social Care, and that I hope will give a broad view of what's going on across social care, and a much more in-depth view than has ever been the case before, and will give a sense of scale and shape and size of issues around PPE, COVID-19 infections, and so forth. And also that will, I hope, in turn enable a number of other organisations to come in and provide support where that support is needed, and that will be direct hands-on support and so forth. So I think it is about CQC acting in its role as reporting and collating information, and then passing that on to other agencies for them to do the hands-on support. We also know that we're having an increase in the number of calls into the NCSC, with people talking about what's going on the front line, and also people who are using services both in health and social care are also calling in to talk to us about what's going on there as well. And we're hoping to roll out what we're calling our emergency support framework, which is our interim assessment methodology. And what that will enable us to do is have structured conversations with providers, so we can get a really detailed and clear view of what's going on a provider by provider basis, and then start to aggregate that up on a regional level, so we can start to see regional variations in what's going on. In amongst all of this, we are continuing to our transformation work, and continuing to make the longer term changes that we know we need to make as an organisation, as well as trying to carry out the shorter term COVID-19 action. So trying to balance those two things at the same time, whilst working remotely is obviously something we're working very hard on. So I'm going to pause there, Peter. I'm not going to talk too much more about COVID-19 yet, but there's an opportunity in a moment to talk about that in more detail. But I'm going to hand over. Now to
Kate
for the next part. Thank you.
Thanks, Ian. So if I could just update board on an outcome to a first tier tribunal for which we received the decision on Monday. So it's a home called Bleak House up in Humberside, a home that currently supports 19 adults with learning disabilities and dementia. The provider applied to our registration teams to extend the service from supporting 19 adults to supporting 24. That application was refused because it wasn't in keeping with our registering the right support guidance, and wasn't in keeping with the spirit of transforming care. The provider appealed the decision. It went to first tier tribunal, and the case was dismissed, and we were positively supported in our position from the judge around the need for services to remain small, community focused, and I think this is an example, as we continue to do the refreshing of the registering the right support guidance that we will be sharing when we get through the kind of COVID period that we're in at the moment, the revised guidance called Right Care, Right Support, Right Culture, that we continue to use the registering the right support guidelines to influence and shape the provision of new and changing services for adults with learning disabilities.
Thanks, Kay, and that's a very encouraging result from the tribunal. So thank you, Ian.
Thank you. If we could move on to. Sorry, I'm trying to scroll between screens and not doing that brilliantly well. If we can move on to to Ted, please.
Okay, thank you, Ian. So as you'll see in the report to the board, we're continuing to publish inspection reports from the inspections we did before the COVID epidemic pause. Those inspection reports have enabled us to make recommendations about special measures in some cases. For instance, last week we recommended Norfolk and Norwich Hospital should come out of special measures, and I'm really very pleased with the progress that trust has made over the last few years. So we are continuing to monitor those trusts that we're concerned about in partnership with NHS England, Improvement and other regulators. And I had a very successful meeting with other regulators and the regional teams from all over England for NHS England yesterday, and we discussed those issues that we have of concern. Of course, a lot of the discussion was around COVID, but we also discussed the other issues that we've been monitoring coming up to the COVID epidemic. I should say that the acute sector has responded really very well to the COVID epidemic, and I want to congratulate all my colleagues on the front line in the acute sector in the way they have raised capacity in response to the increasing numbers of patients with COVID-19. I think some hospitals have been under enormous pressure, and I've heard from doctors and other staff working in those hospitals of the difficulties they've faced. But having said that, I think they have risen immensely well to the challenge that's been faced. And there has been capacity there in the acute sector for the COVID-19 patients. And I think that is a great achievement by all colleagues in the NHS across the board. And Ian has already highlighted that we've worked with the developing Nightingale hospitals to understand their model and to provide them with support as well as part of that work. One of the interesting things is that there is spare capacity there in hospitals still, and particularly interesting, there's been a fall in attendances at emergency departments during the COVID epidemic. And I think there is learning from that, because I think it has identified that some of the attendances in emergency departments that have caused so much pressure in them in the past may not always be necessary. But equally, we are concerned that some people who should be going to emergency departments because of very real health concerns are not doing so because of fear of COVID-19. And we have been working with other parts of the system to ensure the message goes out to people that the NHS is still open for people with emergencies. It's not just there for people with COVID-19. And I think it's very important we encourage people who have real concerns about serious illnesses that they do seek the help that they need. And what we have been raising with colleagues in the other organisations is our concern about patients without COVID and whether they're getting the care they should. I mentioned the emergency cases there, but of course there are also issues in, say, maternity services, where it's important that people who are accessing maternity services feel confident in their services despite the COVID epidemic, and other urgent services like cancer services where we're concerned. But I should mention it's important that providers keep track of elective care. It may be that it cannot be performed at the moment, but those patients need to be kept track of and monitored and risk assessed so that when care can be made available, it is prioritised. And I'm particularly concerned about that sector and long-term conditions. And we're also concerned about inpatient mental health services and services for people with learning disability and autism, because those sectors are affected by the COVID epidemic, maybe directly because staff or patients become infected, or maybe indirectly just because of the pressures on the system means that they don't get the resources they need on a day-to-day basis. And it is very important those services get support as well, and we are providing support to the system to help them, to help monitor what's going on in those services. And particularly I'd like to highlight the work we published around how we're going to monitor the Mental Health Act going forward during the COVID epidemic, taking a slightly different approach, doing more remote monitoring of the Mental Health Act, but being willing to go and review on site if necessary. And I think it's very important that we do send out a message that where we have real concerns, we will still review on site what is happening to patients. I think another important area that we're working on at the moment is around infection control, and we're working with NHS England to improve the guidance available for providers in the COVID epidemic to manage infections in hospitals. It's very important when this infectious disease is prevalent that hospitals can maintain really very high standards of infection control, and that's acute hospitals, but also, as I say, hospitals such as mental health hospitals and where patients are. And that guidance is coming out, I hope, later on this week. And once it is out, we will then be working with providers to monitor their implementation of it, to make sure they provide the safest possible environment for providing care for patients. So a lot is going on in terms of routine work, but also work to support the providers during the COVID epidemic. And the situation we're monitoring on a day-by-day basis.
Thanks.
Thanks, Peter. If I could move on to Rosie.
So just to let the board know that myself and Jan Fuchs-Bale, who's the inspection manager who leads the Health and Justice team, appeared before the Justice Select Committee yesterday to talk about the care of older prisoners. And what we asked, as long as in line with our partners who also appeared as witnesses, was for the Justice Committee to consider a recommendation about developing a national strategy for older prisoners who make up about 32% of the prison population. So there is a real need for that coordination and a national strategy. Ian, I don't know if you want me to talk about the COVID aspects now or come back to that later.
I think probably, Peter, it would be okay if we talked about that as part of the COVID report and try and keep it more close.
I'm kind of, I was going to say that I'm inclined to go seamlessly from this into the COVID report and then open it up for discussion, because already we were sort of talking about COVID and non-COVID related issues.
Yes.
So, Rosie, did you need... Sorry,
well,
I
was going to say, I don't think Rosie's got anything else, have you, Rosie, that's non-COVID?
No, I've got quite a few things to mention that are COVID related, but we can come back to those.
Thank you. Could we move on to Kirsty then to talk also about performance? Thanks, Kirsty.
Just coming off mute. Thank you. So in terms of the performance, I'm going to hand over to Chris in a minute to talk through some of the detail, but I just wanted to pick up on a couple of issues. So in terms of our performance activity, our normal routine inspections have been suspended, so we haven't compiled such a full report today as we would normally do, but just to pull out some of the sort of things we wanted to focus on. Our registration activity has been incredibly busy during this period, with demands for registering of new and additional services to support the COVID application. Our team have had over 162 applications to date, which are directly related to COVID. 9 of those have been fast-track applications, and the remainder have been applications which increase capacity in the system. What we've been doing is prioritising those fast-track applications, and we are getting through those in an average of 7 days end-to-end, which, given that our normal processes can take 50 days plus, that is quite a significant focus and improvement in activity. We're also, for those applications which are adding capacity to the system but which are not so urgent, we are processing those in an average of 7 days, again compared to the 50 plus days that we normally do. So I think we are continually getting applications, we are prioritising those, triaging them and moving them through at pace to enable us to do that. What we're also doing with our registrations is, where it's possible, is we are enabling registration to run concurrently with the application process, so as not to cause an unnecessary delay in the system. And we have a number where we're simply adding services and amending registrations where those are being done in parallel to the application and are causing no delays at all. Just in terms of our people, we have seconded a number of people out into both other government departments and into the front line to support our activity, and also into some sort of other volunteering activities. We currently have over 70 people deployed and are currently, and have a list of people who are have volunteered to go and do other things, and we're working on supporting those people. We are also have obviously with our people now working in a different way, working from home and with a different demand on them. We are looking at how we can support them effectively effectively through our policies. We've pulled together a whole pack of information on working from home to support them to do that, and also looked at how we can move work around the organisation to take advantage of this lull in activity in terms of our normal activity, to work through some of the activity that we would normally do and have slight backlogs in. So, for instance, some of the work on processing normal standard registrations has been moved around to be picked up by our inspectors and other areas like that, so that we can ensure that our workforce are fully occupied during this time. Chris, do you want to pick up the other detail on performance?
Yeah, thanks, Kirsty. So this is our February update, which is the kind of last month before we were heavily impacted by COVID, and seems like a lifetime ago now. So just a few headlines from me, really, which was just around our inspections. We were hitting some good numbers. ASC were inspecting 100% of inadequate locations, 98% of requires improvement. PMS, likewise, 100% of inadequate, 90% of requires improvement, and hospitals were continuing to deliver against high-risk ratings, with 91% being inspected. In terms of safeguarding, we were close to targets on referring mandatory actions, and 93% of mandatory actions and alerts were referred. 96% of alerts referred within target time, both 95% target. And we were seeing an increase in whistleblowing volumes in February, which we were closely monitoring as kind of an increase from the equivalent time previous year. In terms of we have a COVID dashboard that we've set up, so I thought it would be worth talking to that as well as just the routine performance. We have a COVID dashboard that is refreshed daily, so to help us make decisions around our resourcing and also a general response. Some of those areas Kirsty's already referred to, so we're tracking things such as secondments, people with symptoms, and tracking a variety of metrics for people with symptoms, so we can understand that area. Our engagement with colleagues, so we have bulletins coming out, and on average is kind of 80% are reading or opening our updates, as well as a significant number of colleagues joining the all colleague calls and separate managers calls. In NCSC and registration, Kirsty's referred to that already, but we're receiving a lot of inquiries into NCSC. I think the latest numbers we've had is about 24,500 inquiries into NCSC in relation to COVID, so some heavy volumes coming in there, and we're also tracking our inspection activity, albeit small. So we announced on the 16th of March that we'd stop routine inspections. From that point up to date, I think we've done 45 inspections, although I think 9 of them were kind of desk-based inspections in PMS, so we didn't physically visit the service, but it is an area we're tracking. So that's an update from me. Hopefully people find useful. We're happy to take any questions along with Kirsty.
Thanks. I think we'll leave the questions till after we've had the COVID update, Chris, because so much of it is interrelated. But before we go on, just in the written report, Kate, there's a couple of paragraphs on the closed environment work, and it might just be worth reassuring the board that work is still continuing despite all the other pressures on us at the moment.
Yeah, so thank you, Peter. So as we discussed at the last board, we are anticipating bringing a fuller report back to the board in May. However, the issue of closed cultures is more pertinent now than ever in view of what we've just been discussing about inspectors and our regulatory role needing to take assurance through a variety of means when we're no longer routinely crossing the threshold. As I've mentioned before at board, we put out guidance to inspectors prior to COVID about how we should be identifying environments that are closed and the additional steps we should be taking around use of experts by experience, taking more time to involve families, local advocacy organisations, etc. So that guidance is still there and available. There is ongoing work happening. Ted mentioned in his update about the work around Mental Health Act assessments and our commitment still to visit in scenarios where that warrants that. And there is an ongoing piece of work, particularly about surveillance. I know, I think we had a potential question coming from the public about where we are at with our role on surveillance. Can assure the board that we are currently using surveillance in our enforcement work where it is appropriate. And there is an active piece of work looking at the moment where surveillance is gathered through a provider or through another party about how we use that data to inform any action that we may or may not take. So lots of work happening on this issue, even more pertinent as we are in a scenario where we are not regularly crossing the thresholds, and we will have a detailed kind of prioritisation piece to bring back to board in May.
Okay, thanks. So big update next month, Kate. Lovely, good.
Then engagement policy and strategy. I think the headline is that we're spending a lot of time connecting with members of Parliament, and almost all of the MP letters relate to COVID-19 as one would expect. So we're trying to make sure that parliamentarians are updated. We've got one or two colleagues have appeared before select committees by video link. So again, we're supporting where that's appropriate as well. And the only other thing I just want to just pick up on this section is that we've released our report on the sandboxing activity we did around helping digital triage, helping providers look at how to register for digital triage. Although that was released relatively quietly, it is an important report, and it sits there ready to be used for those providers that are starting to think about registration in a digital age, which has become, as we can appreciate, much more popular very quickly. So I think it's important work which will have long-term implications, even if there wasn't a short-term big amount of publicity around it.
Okay.
Thank you. I think then finally, we just wanted to touch on Mark's area in terms of cybersecurity and information.
Yeah, there's nothing to report this month, and no issues.
That's what we like. Ian, shall we move straight into the COVID response paper, and then as I say, we'll open up the whole thing for discussion.
Yes, let's do that. Thank you. I mean, I think if I just say a few words by way of introduction, and then hand on to colleagues, beginning with Rosie, who's been our lead director on COVID from the start. I think if I were to just sort of try and summarise the range of different things that we're doing, they probably fall into four broad areas. One is external support. So we've been working with the teams at the Nightingale. We've been looking to find out what's going on within adult social care area, feeding that back into government. We've had people going from the organisation as volunteers to provide direct hands-on support. So lots of different ways of capturing information, both intelligence and hard data, trying to summarise that and pass that back to government and NHS England and so forth. I think the other area that we've been working hard on is what I describe as accelerating. So accelerating registration. You've heard Kirsty just talk momentarily about the work we've done there. We've redesigned our entire inspection methodology to produce the emergency support framework. And again, what that is about giving us a tool that we can use so that we can be effective in terms of giving the public assurance that they can safely use health and social care as a service. So we've accelerated that work. We've done that work incredibly quickly. And the third area, I think, is around what I describe as innovation, where we've done things which we wouldn't normally do. So all the work we've done around testing, which colleagues will go on and talk about in a moment, where we've delivered. We've done direct delivery of a booking service for drive-through testing to enable people from social care to book themselves a test. as well as working with DHSC and Public Health England on at-home testing. This idea of posting a test out to people. We're working on the pilot with it. These are things that we wouldn't normally do. They're not necessarily core business for CQC necessarily, but we are uniquely placed because we have the information and the connections into the sector. So we've used those connections in order to get things done in the broader system. And then finally, internally, obviously, we're an organisation of 3,500 people, and we've gone from having a number of offices and a large national customer service centre, and we've moved all of that into home working mode. So none of our teams are working in offices anymore. So we're just moving 3,500 people into home working has been quite an undertaking, and making sure those people understand what's going on and making sure that they're fully engaged with what's going on, alongside enabling them to volunteer where that's appropriate. So I guess 4 areas: one is support, one is accelerate, and one is innovate, and one is internal. So I'm going to hand over now to Rosie, just for her to kick off an update on what she's been doing. Thanks, Peter.
So thank you, Ian. There's been an enormous amount of work, so I'll just pick out some of the highlights for this meeting, because I think we'd be here all day if we were talking about all of the different work we were involved in. But firstly, I think the first thing to say is we've had great cross-sector working across the organisation, and I think one of the things that's emerged over the last few weeks that's been very visible is that sometimes the pathways between health and care, and the pathways between primary care and secondary care, there's all sorts of issues that have emerged, which we have been looking at how we can resolve and support across the system. And in particular, that's been very visible between social care and primary care, and we are developing a set of statement to support that interface and outline what our expectations are in that area, alongside many of the other organisations involved. We've been supporting the Department of Health Safety Cell on a daily basis, and they've been looking at a whole variety of work which we've been inputting in, and part of the work around that has been looking at the verification of guidance, death guidance, which we have been involved and contributed to significantly. We've pulled together a joint statement from Ted and Kate and myself, because I think it's very important that we encourage people to look at how they can raise concerns, how they can learn from things that haven't gone well, and really encourage that patient safety culture, which is more important now than ever, that people are able to talk freely about things that they're concerned about or they're worried about, and that they may be learning from. We've been working with the independent health sector, and as well as acting as a kind of communication channel to them, we've sent out a communication around private testing. We were aware of some organisations looking at private testing, sending out private test kits and charging a large amount of money. So we've sent out what our expectations are in that area. We've been working with prisons. There are a whole set of issues about COVID in prisons around how do you shield vulnerable people, people coming in and out of prisons, and a variety of other issues. And our teams have been working very closely with partner agencies such as HMIP and NHS England to look at how do we really make sure people in prison are kept as safe as possible in this current environment. Our dental team have been busy looking at the urgent treatment centres for dentists and supporting the development of those. And I think the final thing and our medicines team have also been working to look at issues around controlled drugs in care homes to make sure that they are managed safely, to put out guidance about end-of-life care drugs, and have been monitoring closely supply chains and other issues related to medication. I think the final issue I wanted to raise is just to brief the board about an article that was in the Daily Mail today, which was contributed to by a gentleman called Dr. Nick Summerton, who is the clinical advisor from
for John Newton. And Dr. Somerton, in his article, was basically saying that we and Public Health England were coming up with hurdles that was getting in the way of the rollout of testing. And I just wanted to address some of those concerns here. He said it was as simple as kind of sticking a swab up someone's nose in terms of the testing, and couldn't understand why we would want training. I think the first thing to say is we are all aware this is a very vulnerable group of people in care homes, and they're not a homogenous group of people. They're a group of people that actually, some will have learning disabilities, some may have dementia, lots of people with lots of very different needs. And we're also aware from discussions that we've had with care providers that they're being expected in some cases to take on delegated tasks, which sometimes they're not feeling supported to be able to do. And it's really important that we make sure that A, we're protecting people, and B, we're making sure that people in care homes get the support and training that they need. I think that it might be as easy as putting a swab up people's nose, but actually if someone's distressed, that is more difficult. There's consent issues, there's capacity issues, and we need to make sure that people feel that they have access to the training that they need. That doesn't need to be hugely time consuming. It might be a 5 or 10 minute video or something similar that people can access, but it's really important that if people are not qualified and not trained in this area, that they have access to support. And it's also really important that actually if they don't feel comfortable to be able to do that, that there are other local options available to them. We won't specify what those local options are, but that is really important as well. And finally, I think it's really important that actually people understand what to do when they get those results back. So that end-to-end pathway of actually, if you've got a lot of your staff who are tested positive, even though they're asymptomatic, or if a lot of the residents come back, we need to be really happy that the advice and the support is there to those care homes to make sure that they get the that they feel that they've got the support to be able to manage that situation. So those were the main things I wanted to mention. Kate may want to add further to the care homes issue, but I just wanted to clarify that for the board.
Thank you, Rosie. Before Kate comes in, I mean, it's probably also worth saying that the only thing that would be worse than not testing would be to be testing inaccurately and getting false confidence out of those tests. Absolutely. If there's a false negative that comes back, and then 30 or 40 of your care residents die as a result of that, that would be a disaster. So it's absolutely imperative that these tests are done in a way that are safe and as accurate as possible. Thank you very much, Rosie. Kate, do you want to come in now?
Yeah, thank you, Chair. So thank you to Rosie and Ian. I won't reiterate the testing point, bar emphasising there are a number of different testing strands here. One is the kind of booking system that we have enabled to happen around testing of care workers who can get themselves to testing centres. The other is what the role might be around home testing and testing of residents, which is quite a different matter, and we need to have the assurance, as described, about people's confidence about delivering those tests to ensure that it gets the results that are accurate. So testing's been a big part of the work that's gone on in adult social care. Since we last met as a board last week, the Department for Health and Social Care published our adult social care action plan in response to COVID-19, and there are many tasks in there that CQC are contributing to or providing a leadership role of. Some of the stuff would be areas you'd expect. So the action plan talks about the importance of our give feedback on care and really encouraging people more than ever to tell us about the quality of care they're receiving or people's experiences as a worker within social care. It talks about our market oversight function and the critical need to continue to have good visibility around the financial sustainability of our providers, and it also references our emergency support framework, our interim approach to regulation. There's a few new things in there. So it talks about the joint leadership role we will be providing with Think Local Act Personal around understanding the impact of the Care Act easements following the Coronavirus Act that was passed maybe about 2 weeks ago. and I will come back to board with an update on that at a future point. One really important thing I would like to just take the opportunity to talk to board about is about data. So when this originally kicked off the COVID work, we were really clear that we wanted to not put a burden on providers through our many organisations' potential risk of asking for data. So we were really keen from the beginning that we would reduce the burden on providers, ask for data once and ensure that that data fed the many organisations that needed to see it, but also led to action that improved outcomes for people with care and support needs. Really pleased that following a lot of work that's been led by Mark and our colleagues around in the digital service, we went live with our new home care tool about a week ago, which is asking all home care providers on a daily basis to take 3 or 4 minutes to complete a form to tell us what the impact is of COVID-19 on people with care and support needs, their workforce, and issues such as supply. At the point of doing that, we also made the decision to switch off our provider information requests within adult social care. So we kept them going a little longer than colleagues in primary medical services and hospitals, because that was our main route of visibility. But actually now we will be having a daily snapshot about what that impact is in the home care market. We're sharing that with the department alongside the NHS England's capacity tracker, which captures that information from care homes, but also the data that's produced from Public Health England around infection outbreaks within care homes. So each day now, the department is getting that suite of data. We've been really keen that conversations about data with the public are clear and you don't have multiple organisations quoting slightly different figures because of how the data has been captured. Until now, we have routinely expected providers to inform CQC of deaths of people who are in receipt of social care. It's part of providers' normal regulations. We made a change to how we asked providers to report that on the 10th of April to ensure that we were getting the completeness of data that we needed, but also we were making it as easy as possible for providers to report to us if people were dying with suspected COVID or confirmed COVID. So from the 10th of April going forward, we have really clear data on that. The Office for National Statistics is the main source of data out to the public. They produce the data daily on hospital deaths, and from next week, from the 28th of April, their data will also include our CQC data. And if you could just bear with me a second while I describe the difference. So the Office of National Statistics data is based on death certificates, so it's absolutely factual. The CQC data is more timely and it's based on what providers are telling us, but it hasn't been fully verified. So we've got an ONS data that's absolutely accurate, but there's a time lag of about 11 days. And then you've got the CQC data that is more timely, but hasn't been fully triangulated. We made a decision between the department and ourselves yesterday, and we shared a joint statement today. On the back of yesterday's ONS data, up to the 10th of April, we shared a statement to describe what the increase of deaths are between the 11th of April and the 14th of April based on the CQC notifications. And it's important to do that because it's telling us a very clear story about what the impact COVID is having on people in social care. And what we said is the data that we have in front of us that hasn't been completely triangulated and verified yet looks like during that 4-day period from the last official reporting of ONS data that there's potentially been a doubling of deaths in the sector. And the other really important thing to say is both us and the ONS are also noting an increase in the number of people dying of non-COVID related issues. And we need to urgently work together across NHS England, all the kind of key partners around the system to really understand what is that increase in the total number of deaths as well as what the COVID deaths are. So I just wanted to particularly flag that issue to board because obviously, it's a really important issue. We've put a joint statement out today, and going forward, there will be a single set of data that will be reported on by ONS. But in this one-off instance, because we now had the most up-to-date data up to the 14th, 15th of April, we felt it was really important to be talking about that to the public.
Okay, thank you. I expect there will be some questions on all of that in a minute from the board, but should we just get the rest of the reports in on the COVID work and then open it up?
can I bring in Ted and then Mark, please?
Okay, well, just a couple of things from me. One, the safety statement that Rosie talked about, I think is really very important, and we did that jointly with Henrietta Hughes, the Freedom Speaker at Guardian, because we think it's really important that the culture out there should be a culture where people can raise concerns. When you're in a very dynamic environment and people are facing pressures, that is just when you need that very open culture. And that statement is going out today, and I think it is really important. There is a great opportunity we must not miss here for us to build a really strong safety culture coming out of COVID-19. And I think one of the encouraging things in this difficult time is that you are seeing people more willing to speak up, and certainly we've seen more people raising issues with us, which we've been able to follow up. And that very important messages coming to us, which we can follow up with providers and other regulators, is something that is really very valuable to us. And we want to build on that. And it's very important we don't get this sense that COVID-19, because it's so difficult, therefore safety second is a lower priority than normal. It is as high a priority as ever, and we've got to keep focused on it. The other thing that I've been doing is working with NHS England and the Academy of Medical Royal Colleges, looking at clinical guidance to try and adapt clinical guidance where necessary to meet the pressures of the COVID-19 epidemic. And the very interesting issue that's coming out of that is that while people are looking at guidance and refreshing it in the face of COVID-19, we're often recognising that the guidance could be much better anyway in the long term. And so there are so in many ways this epidemic is challenging our thinking, and that's going to be models of care and the way we work together, but it is also in the way we clinically manage patients. And I think it is really very interesting that some of the guidance is moving forward, and that guidance and the benefits of that improvement in guidance are going to be carried forward into the future. That's all I say for the time being.
Thanks, Ted.
Thanks, Ted. If I could have Mark and then Kirsty, please.
Yes, so very briefly on the digital side of things, the last 2 weeks have seen a huge focus from us on supporting our response to COVID-19. All of the things that we've described here in terms of that, the short-term measures that we've taken required a sort of significant pivot in terms of our activity. Whilst we've maintained progress on our critical programs like digital foundations, etc. Worth noting that we've had some significant support here from Microsoft in terms of enabling us to stand up some very, very quick systems to enable us to achieve some support for various initiatives, particularly Department of Health, around COVID-19 testing in very short order. So specifically on the first one that we started was around support for the communication and booking process for adult social care staff to be able to get access to testing where it's possible for them to drive to one of the increasing number of drive-through test centres. Since we started that work, which was actually a very short time ago, we've been able to reach now every single adult social care location in England, and also we've now extended that out to GP practices and a number of other key worker groups as well, as Ian described. So that's 32,000 provider locations, and as of the data of last night, we've been able to facilitate over 22,000 members of staff being tested for COVID-19 through one of these drive-through test centres. The other work that Kate mentioned there was around support of gathering of data from adult social care, domiciliary care organisations. So now every single day we've got a very short but important survey that's been completed across our 10,000 domiciliary care organisations that we regulate, and we are gathering and reporting that information back into the Department of Health. The other thing that we've kind of done in tandem as well, all using the same underlying technology platform is to stand up our emergency support framework. So this enables us to have a desk-based conversation with a provider and capture essential information around safety and particularly around the impact of COVID-19 and capture that within a central system. That's and that work will continue as we look to continue to support the system.
Thanks. If I can bring Kirsty and then finish off with Chris.
Thank you, Ian. So from my directorate's perspective, we have largely been supporting the activity from CQC. Our National Customer Service Centre has been incredibly busy supporting the work on the testing that we've been doing. They've been the ones that have been facilitating the emailing out and managing the queries. In addition to that work, they've also seen a rapid increase in notifications coming through. We're now seeing about a 45% increase in volume, and we're working through those quickly to turn them around so that we have up-to-date data and information being fed back into the system. We're also seeing a significant increase in the number of calls coming through to our call centre, and I think I just want to point out that some of those calls are quite challenging calls with people quite often very distressed. Normally, our colleagues work in a large call centre where they have their teammates around them to provide support, and often at the moment are taking quite difficult calls when they're sat at home. So, been working very hard to ensure that they are supported to be able to discharge that function well, and be able to continue to do that work. I also mentioned the work we've done on registration earlier to accelerate our process to ensure that any applications directly related to COVID are managed and through the system quickly. Our people, we've facilitated quite a lot of people to go out on secondment and also to support people to do volunteering as part of their sort of day job. So to add a few extra hours here and there if they want to be able to support and volunteer local initiatives to do that. What we've done is we've put a program approach to all our work on COVID so that we are managing that well, so that we can track activity, make sure that things are being done in a timely fashion, and we understand what the interdependencies are between various activities, and also to ensure that we have the right resources available to support the work at the right time to enable us to continue this work at pace without people being overloaded. We are also now starting to think about our recovery piece, and again taking us a programmised approach to that, really building on some of the learning that we've had over this period and looking at some of the work that we've done at pace and things like the emergency support framework, and thinking about how we can capitalise on that learning during this period to take us through a recovery and out to the other side where we're able to re-establish our sort of business as usual regulatory activity. That will continue over the next few weeks so that we are ready to move at pace when we are able to move around freely and the system is able to start to see some sense of normality coming back. Thank you.
Thanks, Kirsty. If I can finish off with Chris.
Just to talk about three groups of people we've been particularly working with. Obviously, providers, both in terms of the information and guidance for them to manage during the time of COVID, but also their support for the work on testing, their support for the work on the work we're doing around the emergency response support framework, so that they understand both our role and how we are supporting them to access the right information and guidance at the same time. While we've been doing that, we've also been carrying out some, as Chris mentioned earlier, some form of regulatory activity, and also looking for how providers are innovating during this time, and how we've seen a number of examples of how providers are using this as an opportunity to try and test new systems that they were thinking about developing. So what we aim to do with that is to build that into what will become part of State of Care later. In terms of the public, as already been mentioned, Give Feedback on Care is a very important channel. I've been working closely with 50 organisations that represent different groups that we always want to target for Give Feedback on Care to make sure we can maintain the volume of activity so that we understand where there may be risks in the system, and we can use that to direct our inspection resource. and then working with colleagues so that they understand both what's happening on in terms of the guidance that's coming from other organisation, what our plans are, and also that the important point that Kirsty meant, being a link between the emergency support framework and how that links to what we might do in the future of the new strategy. So that the main issues for us is keeping a track of what's happening elsewhere, making sure providers and colleagues feel supported in that, and making sure we can carry on both our role to support the system and our role as a regulator.
So
thanks, Peter.
Thank you. And can I, on behalf of the whole of the board, thank you, Ian, and the whole of the executive team, and through you, all our colleagues, for the really phenomenal work that's been done over the last few weeks. I mean, it's really impressive. And Mark, if you could pass on our gratitude to Microsoft, because I know they've been a really key partner in being able to enable some of this to happen. So, I mean, I think everybody should be very proud of what they've been able to do over the last few weeks. Right, colleagues, questions, comments?
Peter, can I have a go?
Yes, Robert, please.
Thank you. Can I firstly echo your thanks and gratitude to everyone at CQC for the fantastic work they've been doing, both within the normal regulatory activity and the adaptations required for this crisis. I've got 4 questions, and I just put them all there, and you can decide who should answer them. The first is about capacity and the fact that we miraculously seem to have an excess of capacity generated by the remarkable work in building new hospitals, emptying wards and so on. And I just wonder what role CQC has in ensuring that capacity is used to its best advantage in relation to non-COVID patients, if we haven't miraculously got enough COVID patients to fill it. And I appreciate the practical issues there, but I just wonder what our role is, bearing in mind that we are there to make sure there's an adequate service in some way, or to say if there isn't. The second is about testing and our role there, and I'm pleased to see the amazing contribution we're making towards improving access to testing. But there's one area which concerns me in particular, which is the difficulty of access of people or staff in care homes when they appear to be being expected sometimes to travel long distances from where they are in order to get it. And I wonder what contribution we can make there. The third question is about end-of-life medication and the reports that we've seen in the press about difficulties in obtaining that in the community or in care homes, and again what our role might be there. And fourthly and finally, care homes in general have become closed institutions because of the need to protect their residents from COVID so far as possible. And while I appreciate that we are working on closed environments in relation to learning disability and so on, I wonder what immediately we are doing in relation to protecting residents when their relatives can't go and see them. And overarching all of those things, as you might expect me to know, is there anything Healthwatch nationally or locally can do to assist your efforts, both in terms of information coming in and messaging going out, that you would like us to do?
Thank you, Robert. So I think the capacity question probably is one for you, Ted, at least initially. And then there's 2 for Kate around testing and the fact that, as Robert says, care homes have effectively become closed environments. And then the end-of-life medication, Rosie, I suspect that's one for you, probably. But Ted, can you kick off?
Well, I think we were amongst the first to raise the issue of non-COVID patients and the risks of non-COVID patients. And now I think as we're getting through the initial surge of COVID patients and people recognising the spare capacity, I think everyone recognises that the system needs to now focus on patients who do not primarily have COVID, but have other conditions, plus or minus COVID, and of course they may coexist. make sure they're getting the care they want. And as I said earlier on, there's an immediate concern about people with really urgent conditions not seeking the care they should seek. And there's a very strong message going out from all parts of the system to say, look, if you have a medical emergency, you must seek care. You shouldn't be fearful of COVID to not go into an NHS hospital, because the NHS hospitals have capacity and they are ready to provide emergency treatment of all kinds. But I think one of our key roles is to make sure that no group gets forgotten in this. And inevitably, there are some groups that people are worried about, such as the emergency group, very importantly. But there's a whole host of other groups, people with long-term conditions, people who are waiting elective care, who may not be urgent, but they still have very important needs, and we need to make sure they're forgotten. People in mental health inpatient settings that I talked about earlier on, and making sure they are not forgotten in the priority element here. So I think one of our roles, Robert, is to make sure that no group gets forgotten and the risk to all groups gets recognised and prioritised appropriately. And we are working very much with other partners in the system to make sure that's important. I think I was talking to a whole group of hospitals from across the country earlier on this week, and they're all starting to talk about actually how do we reset to deal with non-COVID patients. And we had some very interesting discussions. And the interesting, I think, point was that different parts of the country are at slightly different points in this regard. Some have got lots of spare capacity and are not seeing a major COVID surge, and therefore are keen to free up space for non-COVID patients fairly quickly. Other parts of the country, London, the Northwest, have seen a very big COVID surge, and they really need to develop the capacity. It's going to take them a bit longer to develop the capacity. And that's not just physical space, it is also the staff capacity to look after these patients and to do elective surgery, etc. So that needs to be developed. We are also working, I think, with the independent healthcare sector, and we've been working very closely with them as they develop a new model of care under the auspices of the NHS to provide elective care. And we've had a very good relationship developing that. So I think we are supporting those parts of the service that are developing extra capacity. We're supporting them develop new models of care jointly with the NHS and independent healthcare. And we are encouraging the system not to forget any particular group of patients who are in need of care going forwards. It's a very dynamic process, Robert. We're working with it on a day-by-day, week-by-week basis. So these things will develop, but we are pushing to make sure that no group gets forgotten in this.
Great, thanks. Kate.
Okay, thanks. So if I do the testing question first, so we're talking specifically about the testing of care staff, because Rosie's already described some of the challenges about testing of residents and home testing. So on behalf of the department, as you've heard, we established a national booking system, and since this arrangement went live, I think, Mark, it was on Good Friday, we went from having about 9 test centres available nationally to 25, and those number of test centres continue to rise where there's demand. What's helpful about this visibility we now have of data and understanding the impact of COVID on workforce and absences enables us to develop a heat map that says actually there are particular issues in pockets of the country, and if we've not got a test centre that's locally available, we might need to think about establishing one. And while the work continues around home testing, we will keep an active eye on that, because that is potentially a way, when clinicians are satisfied that the right mechanisms are set up, that's potentially a way of reaching care staff who don't have the ability to travel. So that's a couple of things on testing. With regard to care homes and closed environment. So as you are all aware, we stopped our our standard inspection regime at the start of this process. But during this period, between the stopping the inspection regime and the going live of our new emergency support framework, our interim guidance, inspectors have proactively been having regular conversations with registered managers to have that assurance, to provide that support around how those services are supporting people during this time. We have been really encouraging give feedback on care because we really need to know what people's experiences are who are in receipt of that service. The emergency support framework has been trialled and we're almost ready to roll out, and we will be looking at adult social care, kind of kicking that piece of work off as well. The other thing I would say is I am regularly cited on instances where if there's an issue or a challenge with the care home sector, a local response, which often involves local authorities, CCGs, people from that local health and care system going in and offering support, which is fantastic. Where we need to get to, I think, is what does that offer look like nationally? So this isn't just pockets or variability about what that offer is for care homes. And I have a meeting that I will be going to shortly today, which is looking specifically at that. What is the concrete support offer to care homes that might have some local variation, but is there a suite of things that any care home that has hit this level of issues, this number of work absences, this number of COVID cases, what can they expect from their local health and care community to support them to continue providing safe care? And that's something I would be happy to update board on when that piece of work is a bit more progressed.
Thanks, Rosie. Thanks, Kate. Rosie, end of life medication.
Yeah, certainly. So our medicines team are working very closely with partners to look at all aspects of medication, but have been very involved in this area. Firstly, there aren't any supply issues at the moment with end-of-life medication that we're aware of, but I think one of the messages is it's very important not to stockpile these medications because that might cause problems with the supply chain. The current guidance, there is guidance around medications for end-of-life care, and that is that it should be prescribed and supplied, particularly controlled drugs, in the normal way for named patients, and care homes shouldn't have a stock of anticipatory medicines in their care homes. We believe that with the local hot hubs that are being developed at CCG level, these will hold anticipatory medicines so that if care homes need them immediately, they will have access to them. But our medicines team are very involved, and we're putting out regular communications, and we've got frequently asked questions around that area. So the medicines team are monitoring it carefully. Can I just respond to the Health Watch question as well, because I think we've got some really great partnership working going on with Health Watch across the country, and I've been encouraging our inspectors to reach out to local Health Watches to have those discussions to really understand what the local issues are from that Health Watch are hearing about. Those that feedback is feeding up through our regional escalation and coordination meetings that we're holding, and we have an opportunity through that to share that information through the regional incident units that NHS England have set up, and also through our national channels. So I think that relationship is really, really important at the moment.
Thanks, Rosie.
Thank you very much.
Chris, do you just want to say how we're working with Health Watch England at the moment to go to Robert's final point? Chris?
Sorry, yes, as Rosie was saying, the relationship with Health Watch England is a very important one. I mentioned the Give Feedback on Care campaign. So Give Feedback on Care is our principal way of getting the information from the public. So basically, since we've been in this meeting, 6 people have given their feedback on care to us, and we're using that feedback to drive our understanding of what is happening in environments where we're not going in to have a routine inspection. We've been working with Health Watch England on the rollout of the Give Feedback on Care plan, which includes both social media and partnership activity with 50 organisations, and Health Watch England has been instrumental in helping bring that campaign to fruition. So as well as those local relationships with local Health Watch, they've been working with them nationally to make sure the Give Feedback on Care becomes a fruitful route for people. We've already seen an uptick. Actually, there was initially a down over the first sort of week of the spread of the virus. There was initially a downward movement, but we've since seen a significant uptick in activity, and we hope that will be used to target both our activity as a regulator and the wider action of the systems in local areas.
Thank you, Chris.
Could I
Sorry,
ask?
Liz.
Oh yeah, thank you very much. It was first of all very good to see CQC pulling together so strongly in the face of the crisis in so many different ways, and it was good to hear about Give Feedback on care, and also we've heard about the surge in contacts to our National Customer Service Centre. I suppose I've got two questions about how the experience of the public and people using services is coming into us and how we're drawing on it. The first is, do we think there are any gaps? I mean, I was just thinking, you know, it's more important than ever, for example, that people who are detained under the Mental Health Act are getting in touch and telling us if there are any key human rights issues or issues that they're facing, because we're not going in at the moment. Are there any other groups of people that we feel we're not hearing from? I mean, we've rightly had such a big focus on people in care homes and now domiciliary care services. That's all absolutely great. I was just wondering about people who are employing their own personal assistants, so are not using a domiciliary care agency, but we know there are issues there with PPE, for example. We know there could be issues with people who are facing end of life living in their own homes, rather than in care homes or hospitals. I suppose it's just a general question. Do we feel there are any groups of people that we're not hearing from and we haven't got much data on? The first question. Second question, are we aggregating all this data and drawing on what we're getting from those important partnerships that we have to really pick up emerging issues, before they become bigger problems than they might. And a final issue is, as we move forwards, it's been great to hear some people talk about the learning in different contexts. And I mean, it just struck me hearing the discussions about the data in social care, for example. We know it's a complex sector with many providers, and a lot of progress has already been made in collaboration to really bring those sources of data together and make sense of them at a collaborative level. And I wondered whether we are thinking ahead in terms of how can we build on that for the kinds of data and evidence that we can have both from people's experience and from statistical returns, various kinds, so that we've got the best possible information and evidence going forward when we get into a different sort of business as usual.
Chris, do you want to have the first stab at answering those points, and Rosie and Kate may or may not want to come in afterwards? You're on mute, Chris.
Sorry, to go to your middle point first, we do aggregate the information we get from all sources. In fact, I'm just looking at a document which we share internally and also goes as a part of an update nationally, which is the combination of information we receive from both the partnerships we have and from the information that comes in from the NCSC. And just to talk to one of your points around personal care that isn't regulated, a number of partners that we have, including Health Watch England and Citizen Lab and others, have given us feedback on. So we don't just get feedback on regulated activities; we get wider feedback that comes from people. I think that's important because as local systems make a response, it's important that their response is not just geared towards the regulated organisations, but geared towards their local system. So we do gather that information. I wouldn't be bold enough to say that we cover every group, and I think one of the reasons why we wanted to launch the campaign with 50 organisations is to get everybody, both, so not just a large-scale TV campaign, but actually working with local groups right across the country so that we can penetrate the areas that we wouldn't necessarily work with. So that's why the importance of the collaboration with wider groups. We do pull that information together. There are some, just to give you a sense of some of the issues that are prevalent at the mine, the confusing and difficult to understand information from coming from PHE, particularly around the guidance around COVID and loss of service. So this could be loss of access to service from individuals who have had services withdrawn are the biggest issues from public groups, along with the issues around breaches around human rights, confusing advice about how people socially isolate, and a number of conversations from particular groups that don't feel they've been adequately communicated about what the guidance on social distancing should be. So there's a number of areas that we gather. The information obviously goes to our inspection teams, and we use that as part of both of our what we call our Silver Command, our sort of main body for action, but also to partners in DHSC, PHE, and NHS England. And then we share some of the thinking about that through our regional forums. So each of the regional forums that we have operational colleagues and communication colleagues embedded in those forums, so that we can share information back that comes to local groups. I think that helps.
Can I just add to that as well, if that's okay? Because just to add to the work we're doing, we've started some work around understanding what the vulnerable groups are and what the impact both on COVID and non-COVID are, and looking at how we can quantify that, not in terms of condition or sector, but maybe in terms of the population requirements of those groups. And that's work that we've been looking at over the last few days to build on our understanding from the regional teams, and it's work that we will be continuing.
Good, thank you, Rosie. Thanks, Chris. Any other questions or comments?
Peter, may I?
John, yes, please.
Thank you very much. As somebody involved in change for 20 years or so, I just wanted to reiterate how truly impressive what you guys did over the bank holiday weekend, from being CQC being charged with these responsibilities on the Thursday to delivering on the Monday. Not only in terms of the pace, but the discipline and effectiveness is something that others could learn from in this crisis. And I'm equally truly impressed with how we are learning from that exercise to apply to other areas of our transformation. So thank you. And as a clinician, could I just support Rosie's stance on the home testing and the care home testing? The medical advisor to Dr. Newton, in my view, is just plain wrong. And you are absolutely right to pursue what you do. I think it's obvious to anybody that the process for procuring and supplying PPE and for rolling out testing has needed a bureaucratic enema. But our part in that, I'm confident, is completely slick. And, you know, others may need to look critically at the skill set needed to undertake the task. That's not a matter for us. But my question is, again, a bit like Liz, looking forward, that at the moment the testing is restricted to niche, not our decision. That's how it is. It's a niche testing process. Any exit from this lockdown must have to include a more mass testing, contact tracing, isolation. That's the route out. Are we doing anything to help the system move to that recognition that that's how we need to move out? And I know that isn't our core responsibility, but CQC getting back to be operational is dependent on the lockdown exit, and that is our responsibility.
Rosie, do you want to say anything first off?
I'm really sorry, my connection started to play up during that period of time, so I just didn't hear the last question, the question from John at the end. So sorry about that, John. I don't know if you could repeat it, or if someone else can step in.
I was just saying that to come out of the lockdown, Rosie, requires the testing to move from its niche to much more mass testing with contact tracing and relevant isolation. And I was asking if we are taking part in those conversations to push things in that right direction, which I recognise aren't our core responsibility, but us being back up and functioning is dependent on that exit from lockdown. So in a sense, it's in our interest to pursue that.
So I'm not directly involved in those conversations, and Ian might want to comment in a moment, but essentially I believe our role here is rather a logistical one in terms of making it happen, and we're being directed by the central teams who are leading this. I think our regulatory role in this is to make sure that whatever happens is done in a way that is safe and appropriate for the populations that it's being rolled out to. But our logistical one, I think we're responding to requests as required. But Ian might want to comment further.
Yeah, thanks, Rosie. I mean, I think yes. The stark reality there is we've got colleagues in a number of high-level conversations, a number of high-level meetings on a range of different topics. So we're in the room having those conversations. But as you quite rightly say, John, we've deliberately taken a view that we're not going to start to step outside our competence and our core business, if you will, but we absolutely can bring the right people in. So we frequently will say we don't know the answer to that question, but we know some people who can give a perspective on things. So we're bringing people together. We're having the conversations where we've got ourselves into a position where we are part of the decision making, part of the advice groups in a number of areas, but I do think we need to be really careful, and we've been very disciplined about this around not going into places giving advice, if you will, on areas which are outside our responsibility, if that makes sense. Thanks, Peter.
No, thank you,
Chairman.
Mark. Yes.
Thank you. Firstly, can I say it's really good to see the People Directorate contributing to the overall organisational response, and especially reading about HR business partners working with managers to support our workforce. But I have 3 questions, if I may, please. The first one, thank you for supplying the people stats and the impact on our people of COVID. But I just wonder whether we have seen a spike in the use of our occupational health provider services by our people in this period, especially as we've been hearing today about how working at home is, for some people, much more challenging than for others. So that's my first question, whether our occupational health provider services are working with us and being utilised. The second and third question relate to the executive team report on people. I'm very pleased to see the people plan adapting effectively in this period. I particularly wanted to ask a question about the leadership and line management capability, where the success profiles are currently being assessed and tested. And I just wonder whether they have actually been adapted now with the COVID impact. So because we talk much more about going forward about collaboration, about adaptability, about coaching, about well-being, and whether those success profiles have responded to those future competencies and capabilities going forward. And my final question is a request, I suppose, rather than a question, is the Pulse survey. I think it's a very good idea to do the Pulse survey in May, but could I please ask that one of the 10 questions ask the questions whether our people are seeing action after the survey, because that, if we remember, was at 34% at the big survey. I would just like to be able for us to look at that, especially after everything we've been doing. Thank you.
Thanks, Mark.
Shall I answer that?
If you can, please. Yeah.
Okay. So in terms of the occupational health, I don't know the numbers and whether we've had an increase in uptake. We have been very proactive in promoting our occupational health provider and making sure people are aware of the numbers and the services that they offer. So it's certainly not a hidden service. It's up there front and centre in our response, and I can find out whether we've had an increase in uptake in that for you and let you know outside of the meeting. In terms of the work we've been doing around our success profiles, yes, we're out there now with refining that work with colleagues, and really just looking at starting to lock these down. I think we've already a key element of those has always been around looking at how we empower staff, how we empower our leaders and managers to really own their space and manage their bit of the business well, and how we move from a more of a sort of directive style of leadership to much more of a coaching and development style. So that was already part of the planning. I think in terms of some of the things that we've learned around how we've responded at pace in some of the ways we've worked, the collaborative piece, we do want to make sure we build those into those going forward. So we will be taking that into account. In terms of the Pulse survey, I'm not sure we are working up some draft questions on that. I can certainly take your feedback about action after the survey to back to the team and make sure that they look at how we can incorporate that into those questions.
Okay, thank you, Kirsty.
Thanks. Any other questions from anybody? Perfect. So listen, I just again thank you all very much for all you've been doing, and please make sure all the teams that have been busily working recognise, make sure they understand how much we recognise that they have been contributing. It's been fabulous.
I'll do that. Thank you.
Thank you, Ian. If we could move on to the business plan sign-off, and with one eye on the clock and one eye recognising that we have had a lot of time on the business plan elsewhere, I'm hoping that we can just agree without further discussion the business plan. But at the risk of, I may be tempting fate here, so if anybody has anything they need to raise, please do so. But if not, we'll take that as approved and signed. So thank you very much indeed. And again, Chris and Kirsty, thanks to everybody that's put in a lot of work to get that business plan together. Paul, the ACGC meeting on the 1st of April, do you want to give a quick update on that?
Yes, thank you, Peter. A quick update on that one. There were 5 topics that we looked at: the outcomes from the annual management assurance process, business continuity in the context of COVID-19, and there's obviously been a lot said about that already, an update on cyber security. We had a session with internal audits on progress against the programme for the year, new reports issued, and the draft audit plan for 2020-2021. And finally, a short session with the NAO, updating us on the financial statements audit for the year to 31st March 2020. I'll pick out a couple of points on this. On management assurance, each of the 14 directorates had assessed themselves against 8 assessment areas. So there were 112 different assessments. Overall, 70% of them assessments were good and 30% were requires improvement, which is broadly as for last year. There's lots of richness of information in there for with the directorates and the organisation to look at ways of improving the future. But it was a good exercise, a detailed one, carefully conducted and diligently done. A significant amount of peer review and internal audit reported positively on the way it was performed. So the findings of all of that will be reflected in the governance statement in the upcoming annual report. On internal audit, we were pleased that internal audit had managed to complete all the field work for their programme to the 31st of March, just gone, and for that year. And they're now working on finalising the individual reports. 6 of the reports had been issued since our last meeting, and all were moderate assurance was given on all of those, which was didn't raise any large-scale issues. The committee looked at the plan for next year, and that the right balance was in there between what I would term business as usual, and I'm sure that there is business as usual at the moment, but also that between that and the transformation programme, and we recognise that that plan might need to be changed as new emerging risks came out from the current circumstances as well. And then finally, on the NAO update, it was noted that the remote working is posing some challenges around that, which NAO are working through with our team and hope to overcome. There are also some technical issues in there from an auditing point of view. But at the current time, CQC are working on the original timetable and are monitoring with NAO any emerging challenges which would be out of our control. And if those were to affect the timetable, we'll bring them forward. But otherwise, it was an okay response from NAO on that. So that's all I had to report, and take any questions if there are any.
So given the slightly pessimistic terminology that internal audit adopt on these reports, I think that's quite an encouraging set of reports. Is that right?
Yes, the terminology is never effusive, but that is a fine outcome, is an okay outcome, is what I would say.
Yeah, good. Thank you. Any questions? Excellent. Thank you, Paul. Is there any other business from the board? So we had two questions from the public. One we really dealt with, and it was around asking for a commitment that we would continue to consider the use of covert surveillance. And that was one of the recommendations in Glynis Murphy's report to us last month. And we gave a commitment then that we would be looking at all the recommendations. So I think we will definitely consider, as the wording, covert surveillance, and we're having a fuller report on all of that work, Kirsty, Kate, in the next meeting, aren't we? May meeting. And then the second question is from Robin Pike, and it's asking about the people who receive letters from the NHS classifying them as clinically extremely vulnerable because they had one of a number of conditions and all the requirements and obligations around those people. But some of the people who receive those letters don't think they have one of those conditions. NHS England has advised such people to contact their GP, but according to Robin Pike, some GPs are unwilling to discuss this with their patients, and distress has been caused as a result. And what can they do? I'm not sure how much that's really a question for us, but Rosie, I don't know whether you have anything to say by way of answer.
Yes, certainly, and it is really important that, as we know, that shielded patients are properly shielded and identified at the moment, and I know that practices have been working very hard to get that addressed. I think the first thing I would say is I would encourage people to go and see if they can have that discussion with the GP, because I think there may be conditions that they have which aren't necessarily on the list, but makes the GP think that they are in a vulnerable group. So I would encourage people to try and discuss it with their GP. And then if that's not forthcoming, then I would try the practice manager, because really this does need to be resolved at a practice level. If people are struggling at that point, then I would approach the local CCG to have a discussion. People can come to us if they have concerns about the service that they're getting. We can't deal with the individual issues, and we won't be able to deal with deciding on an individual basis whether someone is in that shielded group or not, but we can certainly log that and put it together with any other concerns we have about the provider or any other feedback, so we can decide whether we need to take any further steps.
Thank you, Rosie. That's really helpful. And that is the end of the public board meeting. So thank you all very much indeed. And we will meet again in a month's time, no doubt, again by video conferencing. Thanks, everybody.